and then use lozenges to continue their... So, as you all probably are aware, oral ketamine is not very well bioavailability, so that's why there's never been a very good oral tablet for it. Whereas the sublingual preparation is a lot more superior, so 40% bioavailability compared to 20% for the oral. It needs to be done through a compounding chemist, and also one which is reliable in their preparation. So, like in Sydney, we use basically two chemists that we rely on. There's a couple in Western Australia, centre users, and there's a couple more which are coming around in different areas. But I think it's important if you're that is one that you know the formulation is going to be used properly. The reason why we continue this is because we found that lots of people who you get a good benefit from the infusion, once they go home, then their doses just keep on escalating if they've got nothing to continue on with. By continuing on something that works on the NMDA receptor and continues on the wind-up, then obviously their morphine doses continue to be... So again, we start with low 20 milligrams twice a day, and then increase it up depending on how their pain levels are. So what happened in this particular study was that there was a certain proportion of patients who didn't get any lozenges, and there are a certain portion who did. And that really depended on the consultant who was looking after the patient. And the interesting thing was that in patients who received lozenges, there was actually 31% of those who were able to cease opioids completely, compared to only 6% who didn't receive lozenges. And so even though this is a small sample size, it's showing us that there is a trend, that the possibility is that if they continue on lozenges after the infusion, then they can continue to stay off their opioids. And so there you're probably saying, well, okay, you're putting them on one addictive drug and putting them on another one. But at the end of the day, you've got something which is not going to result in opioid hypersensitivity and continue to manage their neuropathic pain, and also help to reduce central sensitization in the long term, and has got the potential to also come off this as well. So as a general rule, now what we're doing is putting everyone on lozenges, unless they've got an addictive personality, of course. So just looking at it from another graph point of view, just from the left-hand side there, so complete cessation of opioids in 31% of people who had lozenges compared to 6% who weren't on lozenges. And looking on the right-hand side, the number of people who actually increased their opioid use, in the lozenges were none, but in ones who didn't get the lozenges, there was 11% who increased their opioid use. So in other words, once they didn't have anything on board, then their use of analgesics increased. First line, never. I don't think it's strong enough. A lot of people will come to us, say, from the country and things like that and say, can I just go into lozenges first off? And I don't think that's enough to reduce the central sensitization. So we've tried it on 1 or 2 people, and it does absolutely nothing at all.
Do you ever use it transdermally?
No. I've had patients who have come to me, say, with trigeminal neuralgia, who have been applying it topically. Usually they use it in a cream which is with lignocaine, morphine and ketamine. Some of these compounding chemists, they put it all together. And again, they're usually coming after they've failed those types of topical... Yeah.
Topicals work well.
Oh, they do. Everything works well in certain people.
But for if you have a peripheral injury, and there's not a lot of soft tissue to go through, I find the patients are happy with it.
Yeah.
Wrists, ankles, things like that. But when you're going through I haven't tried it.
Yeah. No, I think everyone has a role in certain, and there'll be people who respond to everything. I mean, there'll be 1 or 2 of your patients, even with CRIPS, who'll say, "Oh, it makes a difference." So, yeah. I mean, this lady here is someone who had TN, so she tried different things. So it's a little bit of a long case, but I think it's an important case to go through. So very, very classical TN, 52-year-old. Had a diagnosis made, responded really well to Tegretol, and then developed drug-induced hepatitis, went on and had decompression surgery and did fantastically for about 5 years. When the pain came back, she was commenced on gabapentin, did nothing for her, had a second decompression, and no vascular compression there, but she did okay for 3 months. Then pain came back again, tried lots of things, had stereotactic radiotherapy, and then went on to all these different medications, so gabapentin, lamotrigine. And then when she came to see me, because she was in such a lot of, she tried all these things and she was obviously got central sensitization, admitted her into hospital and had the ketamine lignocaine infusion. Now, what I tend to do with this is, when they first come in, we start the ketamine first off, and then after day 4, if they haven't responded to ketamine alone, then add the lignocaine. So it's not a starting off of lignocaine and straight off. So there'll be probably about 50% of patients who will respond just to ketamine alone, and there'll be another 50% who need the lignocaine added to it. So in her case, it improved her pain to a point where she was able to reduce her gabapentin and lamotrigine. So it's not just for opioid hypersensitivity, so it can also reduce your antineuropathic medication as well. And so when she left hospital, she was well controlled, and then we started on ketamine lozenges. And the pain was well controlled, and she was one of those people, as you all know with TN, they just can't touch their face or put up makeup and things like that. And that was her really good way of trying to work out whether her pain was controlled or not. And she said that she was able to touch her face and put makeup on and blow her nose and all of that type of thing. And she wasn't able to do that for a long, long time previously. And she got to a point where she was able to come off all of her antineuropathics. So it's a similar way of how people come off all their opioids. This lady's been able to come off her antineuropathics. And this was just on the ketamine lozenges. And even after a year, 2 years, so 2006, even 3 years later, she was pain to the point where she even came off her lozenges as well. But then 3 years later, so pain-free for about 3 years, came off her lozenges, and 3 years later she came back, pain recurred, and got very, very anxious about all of that. And then around about that time is when in Australia, we started getting duloxetine. So rather than readmitting her and things like that, we thought we'll try one of the newer medications. It helped for a while, but then Leptal, which is octarbamazepine that I was talking about on my first lecture, and then finally brought her back into hospital for another infusion. So there's no harm in repeating the infusion if they've responded once before. If they haven't responded to an infusion previously, I wouldn't bother doing it again, just like most things we do in medicine. But in her case, she responded well again, and then we put her back on the ketamine lozenge. So in this particular case, you might be thinking, well, why don't you just start the lozenges again because she responded so well to it? And I think, again, it's an important, when the central sensitization is so great, if you just start the lozenges again, it's not strong enough to dampen down the so we prefer to just get them in the hospital, give them that 7 days again, bring it back down to, hopefully back to 0 again, and then they start at a very good baseline. And then similar type of thing, and then everything's going well. I think in general, you've been hearing lots and lots of during the conference, and it's another one of the things where when you're doing different things, you'll know what are the areas where you can start using another option. Not everything works in everybody, but there are certain situations where you can say, oh, well, maybe this is an area where it's potential to give it a try. So ketamine, we've been using it now in lots of our patients who tend to fail lots of different things. So it's not one of those things you use first line, and it's something which you would use after you've tried all the different options that you've got up your sleeve. And it can be used in a multimodal approach like we do in chronic pain management. Okay, that's it. Thank you.
Well, thank you very much for the very fascinating talk.
Yes.
How does it compare with, I mean, it's got better safety profile, right?
Yes.
That's being tried as well?
I've seen 2 trials done on memantine in the literature, and both were negative, unfortunately. So, yeah, when again, because it works on the NMDA receptor, you would have thought that it'll be quite effective in this as well. Mm.
Do you know what ketamine has other effects?
Yeah, I think it's because of all of those different areas where ketamine works on, because it's not just working on the NMDA receptor.
One more question. You kept saying that the central sensitization is being reduced, but what evidence do you have for that?
I haven't looked at any MRI studies and all that type of thing. Yeah, so I think it's more, I go more on the clinical basis. So I think the reason why it works is because once you have this effect, then the sharp pain, the shooting, the burning, the touch sensitivity, the allodynia, all of those types of things have all reduced down. And as
We just reduce neurotransmission rather than the motor being reduced. That's the reason it recurs probably over time.
no, well, I mean, what we're trying to do is we're trying to help our patients in terms of their clinical symptoms.
Yeah, I
You know,
understand that. But
so-
there's no evidence to show that the wind-up is being reduced.
Well, then you think, how do you know they've got wind up in the first place? So we're not going into any studies to say, okay, this person's got wind up and that's why we're treating them like this, right? We're doing it from a clinical basis as well. So then you have to accept it from a clinical basis too.
So, thank you. That was a really good presentation. We actually use Memantine in our practice. We do outpatient ketamine infusions, a 10-day course. We do a max of 250.
Yep.
That's where we
That's
go.
right.
And we follow it up with Memantine. We have about 35-40% success rate.
Yeah, oh, that's great. Yeah, and we've been thinking about doing the outpatients as well. But I think a lot of these patients who are not very reliable, we want to bring them in a hospital and also reduce their opioid doses in a control. So, I think it's really hard when people are on like huge doses of opioid, then you want to try and do it as an outpatient. It's very difficult. When you're doing a controlled situation where you can say, okay, we're going to reduce by 25% today and then another 25% next day, and looking for withdrawal symptoms and things, it's a lot easier.
So you're lucky you're in Australia. We were just
Yeah.
talking about it before you came.
Mm.
So we have a different system in the United States.
Yes.
We don't have a single payer system. So a lot of things which we do are kind of dictated by the insurance companies.
Right.
But we don't, if we start doing these in the inpatient, we will never get.
Well, we can't do this in an insurance company because this is not approved for anything. So when I try and get insurance patients in, they'll say, well, it's not an approved indication for something, therefore you can't do it. So I've had
Okay.
2 patients like that and they won't allow it. The other thing with Memantine in Australia is it's not on the PBS for pain, therefore patients have to pay for it themselves. And, well, actually they pay for it themselves anyway, so it's a similar cost. Yeah.
Okay, thank you very much, Aaron. Very
Well, good morning, everybody. I'm happy to be here. I'm Dr. Folaju Oyebola, a Nigerian, a pain and palliative care physician. My background is that of anesthesiology, which I practiced for 20 years before moving into pain and palliative medicine. I'm also a pharmacologist as well, so it revolves around. A lot of paper presentations are taking place in terms of using neuromodulation, MAT, ATRP, where I come from with luxury, but we have a serious burden of pain management for cancer patients, and we still have a way of getting by. So I just wanted to share my experience with you on how we do this. I will show you briefly about the cancer patterns and the form of pains. We have a 3-year study of our pain consults received sent to the pain and palliative medicine from other surgeons and physicians. The results show that 75% of them respond to both pharmacological and non-pharmacological interventions. These are the list we have. And the lesson we learned was that the analgesic platform model of pain management is still very, very feasible because we don't have those interventional analgesia stuff. But the challenges we have is that within the health system, the physicians, the surgeons are afraid of making use of prescribing opioid. So it's only the pain society and the palliative care people that make use of the opioid. And when they send the prescription, you see that they are skillful about the prescription. I will show you some of the funny prescriptions as well. Then in their overview, they always underestimate and neglect holistic approach to pain management. So generally, we all lack that skill of interventional approach. So my learning objectives, well, to showcase the multimodal approach, as everybody has been saying. From my little experience here, I realized that the multimodal approach is even beyond what we are used to. Then to explore the non-pharmacological treatment modality that will make somebody reduce the pharmacological interventions. And above all, also support multidisciplinary routine care approach to pain management. This is where I come from, Nigeria. It's about the most populous country in Africa. We are surrounded by Cameroon, Republic of Cameroon, Niger, and the Benin, and the Atlantic Ocean in the south. This is the size. We have a population of more than 170 million. The life expectancy is very small, per capita income very low. The prevalence of cancer, we have about 100,000 new cases annually. And the burden of palliative care in that place is about 4.6 million. This is my center, just a view. Then, we've been talking about pain. We've been talking, this just is one of the side fields. We're talking about pain, and of course, the reference point has always been IASP, which we are familiar about. And the point there is, it has a sensory and affective component. Most of the healthcare practitioners take care of the sensory component without the affective component, and that's a little bit different. Let us look at another definition. This is the definition that we have been using in palliative care practice. As you can see, we want to improve the quality of life of dying patients. Not only dying patients, even other patients suffering from limited life sickness. And the yardstick is that you must have that assessment for the treatment of the pain. Impeccable assessment means you must be very skillful in doing it so that you actually know what type of pain you are managing before you can provide solution. And you can see from the definitions of palliative medicine, palliative care, it's only pain that was actually mentioned. We find out that it's not only physical pain that we are dealing with. We have social, psychosocial, and spiritual problems as well that has to be taken care of. Palliative medicine, we believe that every human being is made up of body, mind, and spirit. So, and let us look at other definitions as well. This was WHO view as far back as 1948. You can imagine. I remember when I was in medical school less than 30 years ago, we always say, not the absence of disease. The definition mentioned physical, psychological, social, and spiritual well-being. How many of us go to that extent? That was in 1948. Probably none of us had his MD as far back as that. And in WHO and said that we should give more importance to the belief and faith of the patient, rather than viewing a patient as a mechanical structure. There must be a seamless connection between mind and body. So if somebody has a pain, you should go beyond that physical pain and handle the mind and the spirit for that three components to align. So how do we manage pain in palliative care? It's the same procedure: physical examination, history, investigation, and diagnosis. But in our own treatment approach, we use the 3 Ps. Just like I've said, the physical, the psychological, and the pharmacological thing. In palliative care or palliative medicine, if you are managing pain alone, you do not do palliative medicine. Palliative medicine has to do with pain and supportive care. The supportive care handles the non-pharmacological issues, like the socio, emotional, and the spiritual challenges. So if somebody is managing pain alone, is not doing palliative medicine, except you have the supportive care to it. And just like the typical tool we use to assess number of pain, origin of the pain, what gravity, how does it radiate, what are the severity. Even when they are in labor for 7 days, head at the perineum, they will not cry. That's the meaning of pain to them. But if you go to the other tribe, they cannot accommodate it. So what is the meaning of that pain to that individual? We try to address it to find solution. The complementary issues, which we all agree with me that pain is subjective. Oftentimes we have objective view about it. The nurses may say this patient is just malingering. But we must take it as being subjective. In my own part of the world, is undertreated because of the assessment and the facility to manage them. And pain has been regarded now as the 5th vital sign in palliative care world. I always tell my nurses, when you go to the ward and you are doing your TPR signs, make sure you ask the patient, what about your pain today? What type of pain do you have today? So it's the 5th vital sign. And what we are now moving on is that pain and palliative medicine should be a fundamental human right of every patient. Let me just briefly go to the study. Yes, we were able to review about 92 patients, and the age range was between 12 and 77 years of age. That is the mean age group. 54.5% of the consult came from the surgical oncology clinic. That means from the surgeons. While the 32.6% came from the GIT clinic, the endocrinologists, especially those who are taking care of cancer, GIT cancer. Then the gynecology, too, we received some consults. Then most of my patients are HIV because I run HIV clinic where I integrate palliative care into the HIV. Some of them present with Kaposi sarcoma. It's usually very difficult to manage. That's on the level of neuropathic pain. Now, this is the frequency of cancer, the pattern. Most of them are breast cancer, followed by chronic liver diseases, cancer of the liver, gallbladder, all stuff. Then the prostate, I can bring that one to urology, then gynecological cancer. That's the pattern of distribution. And you can see graphically. Most of the time, these patients have been with the doctors or the surgeon even for a year, months. They do their physical assessment without that holistic approach. So they are taking the physical pain. Which means the patient lack that supportive care intervention. How are they managing? What are their social problems? The previous medication most of these patients have been on are just paracetamol, non-steroidal, Fortune, which is being used frivolously. Some refer to it as pentazocine. DF11A, dihydrocodeine, tramadol. And we, for about 15 years, opioid was not available in my country. We were blacklisted. So the Pain Society and Palliative Care Group brought the morphine back. And the doctors and the nurses that were trained within that 15-year line, they are afraid to prescribe morphine. So when the morphine came in, of course, when you see a consultant, you say, okay, this is morphine. When they are prescribing, they prescribe morphine 3 times a day, 2 times a day. Wrong diagnosis. So we still really need to do a lot of work and train them. So they have wrong dosage, wrong interval. Even paracetamol in our own environment are being given 8 hourly instead of 6 hourly. These are the things we change around, and we get better results. Of all the patients sent to us, if we use the VAS scale, about 34% of them present with moderate pain, while 76% of them presented with severe pain. Those who came in with moderate pain are either those who have not had the cancer metastasis for too long, or the surgeon realized our positive impact and refer them to us on time. So these are the type of pain: acute pain, chronic cancer pain, and of course, some of these have been mentioned: debility, low backache, and some of them on palliative radiotherapy, palliative chemotherapy, also develop pain as well that we need to manage. Now, this is the big issue where we have added underscore our practice. We are able to evaluate the patients. What are their spiritual concerns? Why me? Why having cancer? The question of existential: if I pass on, where am I going? Those give them and pain. The emotional issues, which you all agree with me, some of them have insomnia, anxiety, depression. Some of them will even deny having the disease. What did the doctor tell you? The doctor say, oh, and these are part of the problem. The socio-economic problem: unemployed, pay for service, they depend on so many people, and they cannot even afford to buy their chemotherapy. I may not go into detail, but just let me say this. If a patient is having financial distress and socio-economic pain, no amount of ketamine lozenges or any amount of neuroimmunization will assist that patient. So you just have to take care of the socio-economic and emotional issue the patient is passing through. So that's why we have come into that word, total pain. That sense of hopelessness, of impending death that may have and aggravate, those ones aggravate the pain. And some of our seniors have worked very well on this. Many of us will have remembered Kobler-Ross, who came up with this thesis that the patient may deny having cancer, be angry about it for late presentation, decide to rationalize it, they go into depression, finally accept, but it doesn't go that way. So their mood, oscillate to and fro, and you must realize where the patient is at that point in time. So you have to manage that. And we in palliative care world, we have been able to follow the full path of Dempsey Sunda, who said we should solve and identify these social, emotional, and spiritual issues. This is a patient, all alone, asking questions: what is wrong with me? You can treat the physical pain, but you can't treat the social and emotional pain. And these are the distress they pass through. In my own area, what are the facilities? Even the facility, they have problems. So this is a case of Ivan in 1986. He was given all, was not feeling better. Was only consoled by his servant, giving him suitors. This is a case in my own center too. A 17-year-old boy with testicular tumor. We gave the necessary analgesic. When we reviewed the following, he was still having the pain. And he said, well, he wants to be baptized. And we looked for a reverend father to do it. And he was baptized. And on the second day, the pain was much more tolerable. So that is spiritual pain. So these are the things we use for and spiritual treatment: prayer, meditation, cognitive. Touch them is a healing. Give them distraction technique. And these are the pharmacology. Our goal is to maintain pain-free, make them pain-free at night, pain-free at rest, pain-free. And we use oral medications. Especially we use a lot of morphine. And of course, the addiction is lowered if you give them orally. And of course, this is WHO analgesic ladder, which lacks this supportive care and behavioral and cognitive thing. I was in Norway last month, and I see some patients who have been on morphine for 6 years. And I asked them, do you have other supportive care to it? Because I have never given a patient more than 20 milligrams of oral morphine. In Africa, routine is oral. So these are the common analgesic drugs we have. And part of the challenge that when the patient is on opioid, because that's the main stake, the organ failure, the liver and kidney, give us a living challenge on how to manage this patient in terms of drug metabolism. Acetaminophen in liver, NSAID in kidney, morphine, and when they have so bad organ failure, we have to play around a lot to make sure that you don't see them to the other side. That's one of our challenges from our ecological approach. And of course, this is the latest approach now, three-dimensional neuromatrix. I'm sure many of us are conversant about it. The input, cognitive, emotion, and the output on there. And we still continue on the pharmacology and non-pharmacological. And this is what has come to replace the WHO analgesic ladder now. When you are giving your strong, weak opioid depending on the ladder, you must introduce physiotherapy, physical therapy, even your maths to reduce the amount of opioid the patient needs. That's the new concept. And it's working even at the level of, mild analgesia. So the outcome measure, 80 to 90 of our patients record 0 to 3 pain score within 4 to 8 hours. If you call me for a patient at 10 o'clock, before I go home, that patient pain must have been reduced. The beauty of it is that we are very lucky. Most of our patients are opioid naive. But in my clinical placement in Europe, I realized that some patients are on morphine 400 milligrams. I can't just imagine. They don't do well for them. So both the neuropathic and pain respond positively to this. And when the patient is having neuropathic pain, you see them after 3 months of the pain. At our daycare hospice, you just give them a test dose of morphine. 10 minutes, they feel okay. They say, ask, why? Where have you been all these days? And we carry on from there. So some of them, even with neuropathic pain, they say opioid is not very sensitive. But when you give morphine, for the first 3 days, whether it's sensitive or not sensitive, the morphine makes them to sleep. And when you review on the second day, they pray for you. Say, look, you have done wonderfully well. For our spinal nerve compression, we use steroid, amitriptyline, and pregabalin. So these are the challenges, just like I've said. We would like to learn new skills to update ourselves. We would like North-South collaboration to improve and partner with people. And I will implore everybody to look into this website. Have been in pain and palliative medicine for the past, since 2001, and has more getting so much positive outcome in government service. So I'm trying to move into my own private hospice to put all this, my experience into practice and make change. You are all welcome. If there is anything you can do for us, please come and join us. Thank you so much for the opportunity of coming.
Thank you very much for quite an interesting presentation.
Probably have time for maybe one question before we go to the break. I was just surprised to see only 1% of your referrals coming from the HIV/AIDS patients. Even in Australia, with probably a lot lower prevalence of HIV, it's probably 4 or 5% of our myself, I'm a palliative physician as well. So I was quite surprised to see only 1% were referred to.
Let me say this. the experience of the world is a bit low. Most of the patients, when they come for treatment for the first time, they present with peripheral neuropathy. That is HIV neuropathy. They can go to any hospitals. They still carry on this burden. They don't see it as anything strange. But it's only those people who know that we have pain specialists that refer them to us. And we're able to manage all those ones. But those ones that was very challenging to us are those ones with Kaposi sarcoma, where the limbs are deformed, they are disabled, and you cannot manage. But invariably, it used to be, when we started around 2006, we have a lot of peripheral neuropathy. But in recent times, with the use of the Medication Act, and we stop all this Tabuday stuff, so the neuropathy is not too much of a challenge.
Interesting. We often see
Good morning, friends. I am Dr. Preeti Doshi from Mumbai, India, and I am going to demonstrate the technique of radiofrequency thermocoagulation for trigeminal neuralgia. This gentleman has a left V3 distribution trigeminal neuralgia, so the surface points are marked to determine the entry point for the radiofrequency needle. A 0.3 centimeters in front of the tragus of the ear is marked, and similarly a point to 0.5 centimeters away from the angle of the mouth has also been marked. This procedure is performed in the operating theatre with the help of multi-para monitor and an anesthetist who's ready to give a short general anesthetic. The patient is made to open the mouth to feel the mandible because the radiofrequency needle has to be introduced medial to the mandible, and also this ensures perforation of buccal mucosa does not occur while introducing the needle. Once the needle reaches the base of the skull, the fluoroscope is oblique to the ipsilateral side to obtain a clear view of the foramen ovale medial to the ramus of the mandible, as you can see here in this fluoroscopic film. Then the final manipulation is done to get a feeling of give-in, and sometimes there is also an egress of cerebrospinal fluid which indicates the right positioning, after which a lateral view is obtained again to check the position of the tip of the needle in relation to the clivus. The radiofrequency lesion generator is ready for stimulation now, where an effort is made to elicit concordant paresthesia to confirm the accurate positioning of the tip of the radiofrequency needle. Sensory stimulation is performed first at 50 Hz, and the patient needs to get a paresthesia at a relatively low amplitude of around 0.15 to 0.2 millivolts. Okay. Now, Jitendra bhai, just answer my question. Is the tingling starting now? The current starting? It is only in the area of your pain. It's not anywhere else. Not higher up in your eye or on your forehead, right? Okay, not even, it's exactly matching with your pain. Okay, now, is it gone?
Yeah, okay.
70 degrees centigrade.
Then it becomes 70 degrees. ठीक है, ऋषभ, उसको change मत करो।
Here is beep at 30 seconds. Do this lesion for 60 seconds at 70 degrees centigrade. Patient is very stable and he's tolerating the procedure very comfortably. Brushing your teeth, shaving, every time it used to pain. Okay, and the finger thi batao exactly where was it hurting you? This. And it was like a current sharp pain. There is no pain just now? Jitendra bhai, your pain is gone? Completely gone? You had your lunch and there was no pain when you ate, right? cerebrospinal fluid, which indicates the right positioning, after which a lateral view is obtained again to check the position of the tip of the needle in relation to the clivus. The radiofrequency lesion generator is ready for stimulation now, where an effort is made to elicit concordant paresthesia to confirm the accurate positioning of the tip of the radiofrequency needle. Sensory stimulation is performed first at 50 Hz, and the patient needs to get a paresthesia at a relatively low amplitude of around 0.15 to 0.2 millivolts. Okay, now Jitendra bhai, just answer my question. Is the tingling starting now, the current starting? It is only in the area of your pain? It's not anywhere else? Not higher up in your eye or on your forehead, right? Okay, not even, it's exactly matching with your pain. Okay, now, is it gone? Gone completely? Okay. At 70 degrees centigrade. Here a sweep at 30 seconds. Do this lesion for 60 seconds at 70 degrees centigrade. Patient is very stable and he's tolerating the procedure very comfortably. પહેલા તમને એ બતાવો તમે અહીંયા શું શું કરવાથી દુખતું હતું અને brushing your teeth, yeah, shaving, every time it used to pain. Okay, and finger થી બતાવો exactly where was it hurting you? Yes, and it was like a current sharp pain. There is no pain just now, Jitendra bhai? Your pain is gone? Completely gone? You had your lunch and there was no pain when you ate, right?
Okay, so basically, let me set the time. It's 11:06 until like 11:30. 11:30, 11:35, let's say. 11:32. Okay.
We got plenty of time, 2 people. Go
Okay.
for it.
So basically, here's the deal. When I talk about pain and toxin, what do you think? How do you think the botulinum toxin works?
Paralyzes muscles.
Okay, George.
It's a neurotoxic substance. It will actually numb it, make it numb.
Abdurrahman.
We have shown it blocks sodium and calcium channels.
Okay, so how does it work with pain? How does pain works?
Well, it's a transmission.
Okay,
It can reduce the excitosis of pain-related mediators.
mediators. Okay, does it work peripherally or centrally?
Both.
Centrally. What do we use botulinum toxin for in neurology now?
Spasticity
Spasticity.
and headaches.
Is it for movement and function, or is it for pain?
It's for cosmetic.
Do they have pain in spasticity? What else do we use Botox in?
Oh, yeah, wrinkles.
Wrinkles. What else do we use Botox in? Okay. So basically, what is pain and what is chronic pain? And what is allodynia? And painful skin. And how does it become painful? And how does the pain become from peripheral pain become centralized? And what is botulinum toxin? How it works? And why should I apply it for pain management? And what kind of pathway they had before? And how is this pathway gonna be worked again? Pain is a combination of sensory and motor symptoms, and there is an experience, behavioral experience into that. It starts acute, but then it chronifies. And if it chronifies, it becomes centralized. And if it's centralized, it's going to be associated with behavioral experiences. And if it's associated with behavioral experiences and it's centralized, there are going to be some peripheral/central disorders like generalized pain, like allodynia, like a lot of muscle spasm. So I could have a systemized problem that is causing pain, like diabetes and Guillain-Barré and immunotherapy and immunomodulated diseases, and I have central neuropathic pain, and I have peripheral neuropathic pain, and I have a combination where I have a peripheral injury linked to central injury and multiple changes. What is this guy having here? The one in the middle here. What is he having? This guy. Parkinson. So in Parkinson, do I use Botox? Do I use botulinum toxin in Parkinson? Do I use it in tremor? In this posture and in this spasm posture, look at the cervical. Is he going to have headache? Is he going to have cervical pain? Look how he's rolling. Do I have some scoliotic changes? And would that works? Do I use Botox in back pain? Would I have any spasm in the paravertebral muscles? Do I have changes? Do I have changes in the scoliotic changes? Do I have a spasm with the scoliosis? Do I have severe pain in such cases in the lower back and others? And would stuff like Botox works? And what is the mechanism? And how does the pain generalize? And how do we diagnose patient? And how does the pain centralize? And is it proven centrally when we work? And if I'm gonna use Botox or other, is that gonna work? And what is the role of Botox or other stuff in inflammation? And is the inflammation centrally or peripherally? And if Botox blocks the acetylcholine receptors, is it gonna block the pain peptides? And what are the pain peptides? What are the pain peptides? Substance P, CGRP, and others. And where is he gonna block that? And somebody said, well, chronic pain is costly and it's centralized, but somebody else said the Botox works, and these are the different kind of Botox which them, and it started as an infection at the beginning. And basically, what we've done it for wrinkles, and then we found out it works. This is how the Botox work. It's a heavy chain, it's a lighter chain, it's connected to a bridge, it connects. The lighter chain goes off, and it starts the the cleavage changes. And what, somebody's phone is here. The heavy chain helps connect the material, the lighter chain goes inside, and the lighter chain does the magic. And then we block the acetylcholine. But is the only thing we block, which is block movement as well? No, we block other stuff, which is pain peptide as well, and this is basically how it works. Now, the other stuff that I wanted to go through is we need to know if we're gonna use Botox. Is there a literature that supports that? And we've went through many indications for Botox, but basically it works through the autonomic movement disorder, and these are the guidelines. These are the indications: blepharospasm, cervical dystonia, axillary hyperhidrosis, and others. And there've been a lot of gaps on how things works, but there've been also something you need to know about botulinum toxin. It's not all the same. Botox is the main company that we know that's being fabricated by Allergan, but there's other companies that's been there in the market. And when you compare botulinum toxin to a botulinum toxin, you cannot always compare all of them the same because they could be different. Well, another thing that I wanted to go over is the other indication that include pain itself, which is low back pain, headache, blepharospasm, hemifacial spasm, and cervical dystonia. Botox was evaluated for different indications, and it's shown that in spasticity it's being a level A in helping not only in the muscular spasm, but also as well in the pain. But for the function, it's being level A. CP, patient, cerebral palsy, doesn't work everywhere. It works mainly on the calf. Is it gonna be painful? It's very painful. These kids come to me with allodynia and can't function and can't walk, and they have a different life style. And when I inject these patients, all their life get a change, and they are functional, they have no pain, they could go ballet for girls, boys, they go to soccer and other stuff. It changed their life tremendously because you're changing muscle and pain. Basically, upper spasticity also works, and it's being level A and level B in that sense. Hemifacial spasm. Am I going to have a hemifacial spasm? Is that going to be associated so many times with headache? Is that going to be a movement disorder or only pain, or both? It's going to be both. Do I have, it's a level C, and I don't have a lot of data on that, but it works very well. I've been doing it, about 100 units, and it's been working very well. Cervical dystonia. In cervical dystonia, there's a focal dystonia, there's a changes, there's shifting, there's headache with it, there's shoulder pain with it, there's restriction, and there is a lot of functional disability, but there's a lot of works. Is there enough evidence that it works? It is also level A, as per all the studies that's been worked, and it's an FDA indication. Headache for the function, for the changes that happen in dystonia, the movement disorder, and for pain as well. It helps very well. It works as well in focal limb dystonia in the upper and in the lower. It works in laryngeal dystonia. It works in tics, and it helps in different issues, tremors, not enough evidence. It's about level C, but it also works and it helps in pain. All the stuff that has a spasticity and it changes and the twistor changes, it works in that. Low back pain. In low back pain, there was a study. It is level C. It works at the paravertebral muscles. It helps decreasing the paravertebral changes, but it also mediated through the pain peptide, and it's been a level C, but there've been a study about more than a study about that. Episodic migraine, it helps an episodic migraine. It's level B, but we've been trying so hard to get approval, and it wasn't until we got the Permta protocol in 2010. It failed for tension headache. It failed for chronic tension, and it only worked for chronic migraine. These are the studies. Also in migraine, we started at 50 unit, we went to 100 unit, and it wasn't approved before we got to 200 unit. Chronic daily headache, chronic tension headache, it's limited responses. Now let's talk about migraine. Is Botox indicated in migraine? It is indicated in migraine. What kind of migraine? Only chronic migraine. Episodic migraine, the studies did not indicate that it works only for episodic migraine. What is migraine? What are the symptoms of migraine? Is every ipsilateral headache is a migraine? What are other symptoms that you want to see in a migraine? Okay. Okay. Parasympathetic, some GI symptoms, changes with movement. If I'm a female, you want to see a period issues with it? Maybe, but not always. How do we differentiate that? And how do we classify that? And why does it work only in, how does it work only in a chronic migraine? So basically, there've been a lot of variations about migraine and about headache. We have to remember the following. To have a migraine, you need to have what? You need to have a brain. You need to have what? Trigeminal. With the trigeminal nerve, you need to have what? Inflammation and what? Some electrical changes. What complex does it use? The trigeminal? Meningeal vasodilation. So it's a combination of electrical. Do they look like seizure, like epilepsy? Is there the cortical depression with that? Is there the cortical spreading with that? Yes. There is. So there is an electrical wiring. There is an electrical changes. Do I have aura like I have with seizure? Do I have an aura in migraine?
You can see it. No.
I can have an aura in migraine. So basically, I have a disease. Is it a disease or a syndrome? A disease, or is it a syndrome? A syndrome, why is it a syndrome?
Other ancillary symptoms that help you to make a pinpoint and the diagnosis.
Okay. Do I have Hal? Do I have mood changes with migraine? I might.
You might.
Do I have irritable bowel syndrome?
You might.
Do I have fibromyalgia-like?
You might.
I might. And do I have GI symptoms with it? Do I have dizziness and vertigo with it?
Maybe.
Do I have neurological changes with it? Do I get weakness and numbness with it? Could it be a complicated migraine? So it is an event centrally sensitized, start peripherally and go centrally. The crazy people approve Botox in a migraine. It's a placebo effect. What do you think, Hal?
I think that Botox changes the nervous system's interaction with the fascia.
It does.
Has a big effect depending where you put it.
Fine. So it works muscles. It works through the acetylcholine. It works through the transmission because Botox affect the acetylcholine and others, but it works also on the pain peptide. And it, as he said, it reprogram the brain. It has a retrograde effect, and it goes backward. I need, when I want to diagnose migraine, I want to make sure it looks like a duck, it feels like a duck, it walks like a duck, it's a duck. So I want to make sure that it is a recurrent to start with, it became a chronic migraine, it's not tension, it's not just a new daily persistent, it's not something called hemicrania continua, which is a disease of the trigeminal process. And I put the different criteria that they went through when they wanted to make them pay Botox, which is millions and billions of dollars. You always look at the different aspects. You will need to remember how it works and how it happened, and where the process, how it's centralized, the changes that happen in the brain, and as my friend said, the interaction that happen in the peripheral and its reflection, and how is the whole trigeminal complex is involved, including the spinothalamic, the thalamus, the sensory, and all of that. And through all of that, the botulinum toxin work and affect all the different aspects of these things. Okay, I want to show you now. I'll show you where we're going to inject, and I show you how it works. So basically, when you want to talk about the areas, I'm going to slide you through so many studies and things, but this is what they went through when they got the preemptive protocol. The preemptive protocol went over different area, and it's a very smart way to ask where you're going to inject, because when we injected first at the face, only in the frontalis and temporalis, it wasn't enough. And then when we started injecting as well in the occipital, as well as in the upper trapezius, and in the other areas, it works. Basically, it's a process. There's an action potential, and it works where the botulinum toxin goes inside, heavy and light. The light will go inside. It will link to the snare. The snare blocks the acetylcholine, but it also works on other entities, which is CGRP and substance P, which are the pain peptides, and block them from working. Then we went over the muscles, corrugator, detrusors, and frontalis, and the studies, of course, this is the CGRP and dural as well as peripheral, because it's a retrograde. Whenever you inject Botox, if you do a functional and MRI, you will find it in your brain eventually. The Botox material. Yes. 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 Well, until now, they do not have a straight, clear, straightforward, clear.
Even people with very chronic pain, they have a very significant reduction in pain because just by injecting saline also.
Hal, what are the percentage? What are the percentage of a placebo? If I injected somebody with a placebo, I mean, what is the percentage of placebo?
So there have been very well-designed randomized trials where they have ruled out the placebo effect for Botox injections. What he's talking about is sensitization and modulation of pain, which is happening at different levels.
Thank you.
Central and peripheral. So when you do Botox, it's essentially minimizing the modulation of pain at the peripheral level, and extent of that modulation is happening and extending
But
the
mostly
central
doesn't
levels.
it come from the meningeal innervation?
So the pathophysiology is still, we can have a discussion
okay.
and we can.
Okay.
Okay.
If I may add something, there are some animal studies showing the transmission of Botox very quickly to DRG and also dorsal horn of spinal cord. So that's why it works both peripherally and centrally.
And this is exactly what I said. It's a retrograde. It goes all the way to the dorsal horn and up to the brain. So basically, when you decided to inject the Botox, you wanted to address a nerve and a muscle. Not only a muscle, a nerve and a muscle. So basically, when you are thinking about injecting the muscle above or the muscle below, you are working on, or the muscle above, you're working as well on the nerve. The supratracheal, when you're working with the frontalis, here when you're working with the detrusors and the corrugators. So basically, you have to inject 7 in the face, which is about 35 units, detrusors, corrugator, frontalis, and then you have to do the auriculotemporal nerve, and you're doing the temporalis, and you do 4 of them here. And as he said, it took us from 1998 when they found out it works for patients who had cosmetic effect. It took us until 2010 until it got approved. For chronic tension headache, it didn't work. We had to go through a very well-designed study to get that approved. In the back, it has to work on the occipital region, occipitalis, greater occipital nerve, and the third occipital nerve. And you both basically put 3 in here. And this is 4, 3. Then you put 2 in the cervical, paraspinal, and then you put 3 in the trapezius. It's 155 units, and you could go up to 195 units by following the pain after that. So basically, what I said so far, before I go and put the studies that we addressed after that, I wanted to put all the different works that went through the preemptive protocol and the different guidelines and the different, because always when you think of Botox, you think of placebo. We basically went over the following. Botox work for neuromuscular because it works over acetylcholine, it relaxes the muscles, it blocks the spasticity, it is level A. Cervical dystonia, it's a level A. Cerebral palsy, it works with movement disorders, including tremors, it's a level C, and it works in back pain, which is a level C, and it works in headache. And I don't have a final study what level it is so far on Botox. We've worked with the Botox in our own studies with cervical pulse radiofrequency applied at the facet with using Botox, where I work at the facet and to relax the pain in the paravertebral region, I apply the Botox. And we found that the accumulated effect is stronger than only using either. We've also combined it with shockwave therapy, especially in the cervical headache, and we've seen a strong effect. We've talked with Hal, the first aid, about inguinal pain that you see it a lot in athletes, or you call it compartment syndrome, whatever. And basically, I've done ozone in this area, I've done trigger point in this area, dry needling in this area, I refer that to rehab, and I've done Botox, and we've seen an excellent response with that. We've used it for transformed migraine. What is transformed migraine? It's a migraine that became a chronic, that you are using a lot of over-the-counter medication, tramadol, narcotics, and others, and it helps change the allodynia and the chronic pain into more recurrent migraine, episodic migraine. We've worked with Botox with the scoliosis, with the spasm and shifting and persistent pain, where the patient is having a function problem and severe pain, and we were able to do an excellent studies with that, where the functionality has improved and done better. We've done also shoulder pain with that, as well as cluster headache. A cluster headache is one of the very difficult headache that stays there and linger, and it comes in episodes and severe episodes, and patient did very well. And this is a thank you from Headache and Pain Center in Jeddah, Saudi Arabia, and this is the team that makes everything work for us. It's not me. It is this team that's holding the infusion, holding the Botox protocol, holding the everything, the fluoroscopy, everything. We're running from one place to another. Thank you guys for allowing me to talk to you.
Well, thank you very much for very interactive and provoking talk. We have time, maybe.
Two questions, two questions, sure. Anybody?
What's the effect on dopamine?
Of Botox?
Yes.
I don't know. We don't know. Okay? I don't know if they have a complete studies on that, but what is the effect of dopamine and serotonin and norepinephrine on migraine and headache? Very strong effect. Effect of migraine on dopamine, very strong effect. This is why they are irritable and they have a lot of moody changes. And it is central and others? Yes. Do I think if I change pain and I change the recurrency of having recurrent migraine, that's going to stabilize mood? Of course it will. Is it going to have an effect in other way on the dopamine? Yes. Is it going to have a direct effect on dopamine? We don't know.
Okay, thank you very much.
All right, good morning again. Thanks for having me again. A complete shift from spinal cord stimulation, neuromodulation, to a completely different topic, which is a little bit close to my heart, cancer pain and rehabilitation. As I said, I practice in Rochester, and we have developed this very unique cancer pain and rehabilitation program, and I wanted to share my experience. The goal was to bring the expertise of pain medicine and rehabilitation medicine under the same umbrella. So with today's talk, we should be able to identify the basic tenets and principles of cancer pain and rehabilitation, and in the managing compendium, we should be able to understand different types of cancer pain and how they affect and manifest themselves, and able to identify an appropriate referral source for cancer pain and rehabilitation patients. So in 2006, Institute of Medicine came out with their recommendations on cancer patients and cancer survival, their first recommendation in this report was that a survivorship is a distinct phase of care. And every patient, every cancer patient should be given a survivorship care plan. So what do we mean when we say survivorship care plan? So if you look at the whole compendium of cancer pain, patient's first step is diagnosis and staging of the cancer, and they move on to either treatment with intent to cure or a palliative treatment based on their staging. Once they have either completed their treatment, they will fall into these categories. Either they will have a survival-free phase, or they will develop certain kind of complications because of the treatments. It could be chemotherapy-induced, surgery-induced, radiation-induced, different physical impairments which they have to deal with. So the survivorship care plan has a role in all these phases or outcomes of treatments, where patients have developed certain physical impairments and they're not able to do their activities of daily living more cogently. And that was their recommendation, to involve a survivorship care plan in the overall compendium of the cancer pain. In the United States, in order to call yourself a cancer center, you have to be approved. You have to be approved through Cancer of Commission. So the COC accreditation for cancer pain involves a rehabilitation specialist. You ought to have one in order to call yourself a cancer pain center. So who is a rehabilitation specialist? He's an expert in rehabilitation medicine as determined by their education, their expertise, their board certification, and clinical experience. It could be a physiatrist who is a board-certified rehabilitation medicine physician, or physical therapist, occupational therapist, speech-language pathologist, or even a rehabilitation nurse. An appropriate referral to rehabilitation for cancer is inability to return to previous activity levels, including work, home, recreation, and social structures. So how do you insert cancer rehabilitation into the survivor care plan? It's essentially education. You talk to your oncology colleagues, you talk to your palliative medicine colleagues, and educate them about the importance of incorporating a rehabilitation-focused model of care for their overall well-being. Now, you got to track your outcomes, you got to make sure that you're following those patients along. There is a concept of what we call a pre-rehabilitation, where trying to identify those patients up front before there are certain treatment modalities. For example, if a patient is scheduled for cisplatin-based chemotherapy agents, you're anticipating a 35% probability of developing neuropathic pain. Similarly, all these treatment modalities have certain physical impairment rates associated with it. So as a pre-rehabilitation concept, we can identify those patients and prepare them for their treatment modalities as well, so that they can go through the surgery, they can go through the radiation, they can go through the chemotherapy agents without significant burden on the physical impairment in future. Just an example of how a breast cancer patient can be referred to cancer rehabilitation. All these conditions can be the referral source to the cancer rehabilitation specialist. Dr. Chevelle actually published a really great paper in 2010 talking about the evidence base of the need for cancer rehab in the compendium of care. So the conclusion of the study was there was more than 90% of the patients who actually need cancer rehabilitation, but unfortunately only 30% of them have access to the Center of Excellence or the cancer rehabilitation model per se. A part of the reason is insurance. As we in the day and age of moving towards accountable care organization, we're struggling with justifying a lot of modalities and a lot of services which we offer to our patients. A lot of things are kind of dictated to us by their reimbursement or their coverage through the insurance companies. But if we include the rehabilitation care in the total compendium of cancer management, I think we can definitely make the whole program self-sustainable and fiscally viable, because all these services which are included in the rehabilitation program, which includes from prosthesis, orthotics, all those modalities, their speech evaluations, swallowing evaluations, medications, all these are reimbursable. They have specific CPT codes so that we can justify their presence in the whole compendium of care. So the elements of Survivor Care Plan includes the interventions for treatment-related side effects, the biopsychosocial services, the community resources, vocational services, and as you can see, there are a lot of services here which are non-reimbursable. But if you include cancer rehab in the same umbrella, then all those reimbursable services like rehab, like pain, can offset the cost for non-reimbursable services like vocational community resources, and we should be able to get our cancer patients back in the community with good community reintegration with these strategies. So with that, I'm going to just change my focus and spend a few minutes on cancer pain. As you all know, cancer pain can be of three basic types. It can be somatic, visceral, or neuropathic. Somatic pain is primarily described as dull, sometimes sharp, localized pain, mostly musculoskeletal or originating from tumor or mass effect. This is an AP view of the pelvis. This patient had metastatic breast cancer, and you can see the lesions in the right pelvis. You can see the fracture and the metastatic lesion. This will primarily present as a somatic pain in the pelvic region. Visceral pain, on the other hand, is a completely different presentation. It's not well localized. It's a referred pain. It's primarily because of the infiltration of the thoracic, abdominal, or pelvic viscera. This is an image where you can see the metastatic lesion in the capsule of the left lobe of the liver, and this patient will primarily present as visceral pain. Neuropathic pain, on the other hand, is a completely different animal. We still don't know the complete pathophysiological basis behind development of neuropathic pain in our cancer patients, but it's related to either the side effects of chemotherapy, radiation, or the actual compression or infiltration of the nerves or nerve roots. You can have cranial neuropathies, you can have post-herpetic neuropathies, your brachial plexus neuropathies, or even, as I said, post-radiation. A lot of chemotherapy agents are notorious to cause these neuropathic pain conditions. This is an MRI T2-weighted image. Actually, it's a T1-weighted image where you can see the cord compression from the metastatic lesions to the body. So this kind of gives us an idea that cancer pain is pretty complex. It very rarely presents itself as an isolated somatic, visceral, or neuropathic pain. Most commonly, in fact, 40% of the cases, it's a combination of either somatic, visceral, somatic, neuropathic, or a combination of all these things. Rather, it may also involve some of the inflammatory components to its presentation as well. I would like to kind of delineate these features with the help of a couple of case reports to help you understand how challenging it can be to identify these isolated presentations and how we can use certain interventional techniques to appropriately manage these patients. So the first case report, I have a 50-year-old subacute onset of somatic, visceral, and neuropathic pelvic pain, recently diagnosed with stage 4 cervical cancer. Length of stay in the hospital was about 15 days, and as you can see, I'm just going to kind of go through. So this patient, when we were consulted, was maintained on 50 milligrams TID dose of methadone, gabapentin, that's a maxed out dose in 24 hours, a dilaudid PCA with a 20 milligrams per hour continuous dose, and a bolus of 10 milligrams Q10 minutes, and a 15 milligram IV rescue dose, in addition to a duloxetine. So, this is it. You can't go you can't go, you can't have any other, medication management for this patient. Any ideas from, from the experts in the room? What's the next, how do you go from here?
So, there's a couple of things. First of all, do you mind something? All right. So, we talk a lot about somatic, visceral, and neuropathic pain. I would argue, first of all, that a lot of what we call visceral pain is a combination of visceral afferents and visceral sympathetic parasympathetic, which we're going to call some form of upregulation or neuropathic pain. I think what you're doing, and we see this a lot now with pelvic pain, is that a lot of these patients that are presented with either radiation or chemo or prior adhesions that they've had before, we're seeing the sequela of the insult. And I talked a little bit about that the other day. So I think in some of these patients, and some of these people have the chronic abdominal and chronic pelvic pains, it may be reasonable to block some of the other visceral pain generators. So whether that means celiac plexus blocks, splanchnic blocks, or some of the superior hypogastric plexus blocks, that will help you dice out what of that is neuropathic, and then you're left with dealing just with the somatic afferents.
Exactly. So that's what our thinking was. As you said, absolutely right. Our thinking was, maybe it has a predominant component of neuromodulation happening at the sympathetic level, or maybe this patient has a sympathetically maintained component. So we actually proceeded with the diagnostic superior hypogastric plexus block. To the contrary, patient only reported about 25% improvement in their pain with the superior hypogastric plexus block. But then it was a complete shift. So we thought maybe, you got to work your way out. Either you work your way in or you work your way out. So, so we proceeded with a diagnostic ilioinguinal and iliohypogastric nerve block, which gave us a 40% improvement in the overall pain reduction. With that information at our hand, we actually proceeded with the neurolysis of both superior hypogastric plexus and ilioinguinal iliohypogastric nerve. With we actually used 6% aqueous phenol for our ilioinguinal and iliohypogastric, and we used 100% alcohol for our superior hypogastric plexus block for neurolysis, and the VAS scores decreased from 9 to 3. Dilaudid PC was gone, bolus only 5 milligrams q10 minutes for 10 days post-neurolysis, and we were able to discharge the patient home with just oral methadone. So that kind of gives you an idea about the diagnostic utility of diagnostic blocks and trying to identify these different pain presentations of the patient so that you can guide your treatment options based on their presentation. My colleague here from Nigeria talked about the WHO ladder, and I completely agree. If you follow the WHO ladder, about 80% of the time you will be able to control the pain, but still you will have those 20% patients which will fail to respond to the WHO ladder. So what do you do with all those 20% patients? Obviously, you kind of go through all these points and try to figure out if the ball has been dropped. If not, you're going to move on to the next step. Dr. Timothy Deere from West Virginia, he actually proposed a fourth step in the WHO ladder where kind of involving or incorporating the invasive treatments early on, or if a patient is not showing their pain, don't get just stuck at a particular level. Just move on and out of the box and try to figure out where that pain is getting modulated so that you can manage that appropriately. So advanced cancer pain management involves, interventions, blocks, neurolysis, epidurals, intrathecal pain pumps, lidocaine infusions, ketamine, and even sedation. So I'm not going to be talking about all those things in detail, but I do want to just briefly talk about just one more case here of a 57-year-old male with metastatic squamous cell carcinoma of tongue and larynx, status post resection and radiation, admitted for uncontrolled unilateral somatic neck pain. Length of stay was about 10 days, and this patient was on methadone 30 milligrams q6 hours and hydromorphone PSA, continuous and bolus doses. This is the picture. You can see the open defect. This patient is status post radiation, so this is the radiation effect on the skin, which you're seeing. we actually did a diagnostic deep cervical plexus block, which was positive, and we proceeded with an ultrasound-guided deep cervical plexus neurolysis with 6% aqueous phenol. Patient's PSA was weaned off in about 5 days. There was a 70% reduction in the opioid usage, 50% reduction in their VAS scores. Patient was discharged home on oral methadone and oxycodone. This case report is a first successful deep cervical plexus neurolysis ever attempted in humans. With that, I think I just want to conclude and bring everything together. The cancer pain can be from cancer itself or from cancer-related treatments. It can be somatic, visceral, or neuropathic. Always assess your patient, ask them about different presentations, try to figure out what kind of presentations they are having, and tailor your treatment modalities based on their pain presentation. Choose non-opioid and adjuvant carefully, paying close attention to the side effect profile. Definitely use the WHO protocol, the WHO lateral guidelines when titrating the pain medicines. If you're stuck in a limbo, if the patient's pain is not improving, move on to the next stage quicker rather than just waiting and trying to just mess around with the doses at that time. So with that, I think I'm going to end my presentation. And I'll take some questions if there are.
Oh, thank you very much. A very interesting talk.
Thank you.
Any questions?
So, first of all, you play an arena different than I. I don't see a lot of the cancer stuff, so I don't get to use the alcohol or the phenol. With 6%, did the patient have any motor function after you did the deep cervical?
I'm sorry?
Did the patient lose any motor function after you did the deep cervical block?
No.
Because the 6% was relatively specific for sensory?
Yes.
Okay, great.
So if you look at the cancer literature, if you go beyond 8%, that's when you start motor fibers. So 6% is preferentially you're playing around with that realm where you're preferentially blocking the sensory fibers and actually neuralizing the sensory fibers. Phenol also has an analgesic effect. So that's another component which plays into the positive outcome in this case.
Have you done it with brachial plexus?
No.
And how many I got a loud voice. Oh, I'm sorry. So how many cc's did you put in the deep cervical?
C3, C4.
Now, how many cc's?
Oh, so 1.5 cc's at each root.
Okay. And it was 6% phenol. Okay.
Yeah, 6% phenol. It was stabilized. So phenol is such that you have to compound it. You can use glycerin, or you can use just plain aqueous phenol. Actually use 25% glycerine to make sure that it doesn't extend. So we played around with different concentrations of the glycerine, because if you use just aqueous phenol, it can just spread all around. With glycerine, you can be very specific in its translation. So we did it under ultrasound guide. We were right on top of the root and just placed some 1.5 cc's of phenol with 25% glycerin there.
Nobody's tried any of this stuff on non-cancer pain, right?
No. Well, so there is a lot of literature about neurolysis, peripherally celiac plexus. We do a lot of celiac plexus neurolysis, but deep cervical plexus, no. There has been no case report, no mention. We actually had to do some cadaver stuff first before actually doing the intervention on a patient.
What was the patient's prognosis overall in terms of, it's me.
Sorry.
Was the patient terminal,
Yes.
So,
yes.
I mean,
The patient passed away in about 9 months, but the quality of life improved so much. He was in the hospital for about 10 and he was not able to spend the quality time with the family. He wanted to die at home. I mean, there was an option of going hospice, but his pain was so significant that he kept coming back to the hospital. So we actually just, took the informed consent and
Look,
proceeded.
This is an area that I practice as well in pain and palliative medicine, and I'm a big believer in introducing interventions early on in managing cancer pain. The reason behind this is often because palliative physicians are very opiate-driven in terms of what they use for managing the pain. It really affects the quality of the life for most of the patients. Whereas when you use a simple block, it can change the whole story about them.
So where I practice, I do a lot of intrathecal drug delivery. Once you have a working relationship with your palliative care physicians, your oncologists, and if you can incorporate intrathecal drug delivery early on in their treatment, it just changes their quality of life significantly.
Yeah. Just simple peripheral block
Absolutely.
can help a lot. But
Absolutely.
my issue with the permanent neurolytic blocks is that often if the prognosis is more than probably 6 months, you will be in trouble with type pain. So you got to be very careful with the patient selection, obviously.
Yes, that's absolutely true. So that's why we never do neurolysis in a non-malignant pain patient.
Yep.
That's where the neuromodulation comes in. So if I'm unable to do a neurolysis for a plexus or a nerve, when I'm dealing with non-malignant pain, that's where neuromodulation kicks in. Peripheral nerve modulation, peripheral field modulation, spinal cord modulation, with the help of spinal cord stimulators. I completely agree with you. Deafferentation pain is a pain in itself. And the complication rate is as high as about 65% in nerves which we use alcohol or phenol to neuralize them. So if you're absolutely right, if the prognosis is more than a year, 2 years, then we are bound to see that horrible deafferentation pain syndrome.
You can do nothing about it.
Well,
it's very hard to treat, really.
yes, it's hard.
You have to see only one of those deafferentations to be very, very careful with your next patient, going for a permanent neurolytic block. So patient selection is really, really important. If I may just also ask you a question about, because cancer pain management is changing, particularly with the chronic cancer treatment-related pain. It's becoming more of a chronic disease. It's an area that has very little in terms of the literature. What's your experience with that?
So that's where our experience of bringing cancer pain and cancer the same umbrella. You are seeing more of cancer survivors now. So that's why we have this survivorship care plan for all those patients who have survived their cancer, but they're left over with some permanent impairments, physical impairments, which can be debilitating. So if you include the cancer rehab folks and cancer pain folks early on, so that they can identify those patients early on and be more aggressive in managing them, I think the outcomes are going to change. You're absolutely right. There are no studies, but I think that's where we start. We start early on. Educate the oncologists, educate the palliative care physicians to get patients involved early on in their care, so that we can manage them appropriately and minimize the burden of care down the road.
Excellent. Any other questions or comments? Well, thank you very much again for an excellent.
Thank you.
Okay.